So good afternoon, everyone. I am Naya. I'm a first-year medical student. Today I'll be presenting the endocrine PAC session along with my colleagues Hosna, Torshabi, and Mohammed. Okay. So basically, let's just have a quick talk about endocrine. So basically, endocrine is one of my favorite chapters, and I hope that you guys are going to enjoy it. Endocrine is where you're going to feel yourself as a doctor diagnosing cases with hints, signs and symptoms, treatments. You know, questions are going to be a bit fun to solve, and I hope you're going to enjoy this session. Okay, so let's start. So before this, there are two major systems in our body, the endocrine system and the nervous system. They are a bit similar, but they still have some differences. Can you guys tell me what some differences do they have? Come on.
We promote an interaction with the body.
Sorry?
The endocrine sends more hormones, and the nervous system is more electrical.
Okay.
Endocrine between the and nervous system between the neurons and the axons.
Okay. Guys? Yes?
Yeah, the endocrine system takes longer to act, but the nervous system is faster.
That's true. Okay, so nervous system is basically made up of neurons that travel all over our body. Endocrine system, blood is the way it delivers its message. Okay? So endocrine initiates response very slowly, while nervous system can initiate it rapidly. Endocrine duration response is a bit longer. Its effects can vary from seconds to minutes to hours. While nervous system is just a click of a second, its effect is done. It also has action potential of the neurotransmitters, while in endocrine we have hormones, which are chemical messengers. Nervous system delivers its message to a specific location, while endocrine system delivers its message to a diffused, to your whole body basically. It acts on every cell in your body. Nervous system acts over a very short distance, just the distance of the neuron, and then it transmits the signal. For endocrine, it can act over a long distance because blood goes all over your body. So basically, it delivers its message to all over the body. We have two types of glands. We have endocrine and exocrine glands. Endocrine glands are ductless glands, and because they are ductless, they are richly vascularized because they produce chemical messengers called hormones, and these hormones diffuse through the gland to the blood to go to its target site. While exocrine gland, they are ductful, they have ducts, and these ducts produce non-hormonal substances. What are some non-hormonal substances do we have? Sweat, and
Saliva.
Saliva. Okay. So endocrine organs, they're basically called glands. These glands include the Pituitary, Thyroid, Parathyroid, Adrenal, and Pineal glands. These glands are what we're going to discover or revise today. What about the hypothalamus? What do you call it? Sorry? Master of? Okay. So it's not a pure endocrine gland, it's a neuroendocrine gland. It's a neuroendocrine tissue, sorry. Because it acts on the nervous system as well as the endocrine system that we will revise later on. There's also some endocrine tissues that are scattered here and there in our pancreas, in the gonads, and in the placenta. Okay. There are also some type of other chemical messengers in our body, but they are not classified as hormones for a reason. Do you guys know what's this reason?
They're short acting. What is it?
They're short acting, exactly. Their effect is just local to the tissue they are in. We have autocrines, paracrines, and juxtacrines. Juxtacrines is in the 12th edition, I believe, but it's not in the 11th, right? Yeah. Okay. So basically, autocrines, they are chemical messengers that are released by a cell and they act on the cell itself. For example, we have prostaglandins. They are released by smooth muscle tissues, and they act on the smooth muscle itself to contract even more. So it's an autocrine. It's a short distance acting chemical messenger. Paracrines, they are chemical messengers that are released by a cell, and they act on the cells that are adjacent or near to it, neighborhood cells. For example, here we have somatostatin. It's released by one population of pancreatic cell, and it inhibits the release of insulin by neighborhood pancreatic cells. Juxtacrines, they are very, very, very short distance acting chemical messengers. They act on cells that are adjacent to the cell releasing it. For example, we have gap junctions between animal cells, and it facilitates communication between them. Okay. Now, hormonal chemical structure. The chemical structure of a hormone is what determines its water solubility. Hormone chemical structure could vary from amino acid structure to a cholesterol structure. Okay? And that's how we classify them into amino acid-based hormones and steroid hormones. Amino acid-based hormones are made up of amino acids. They vary in length from derivatives to peptides to polymers. Steroid hormones, they are typically made of cholesterol, and because they are made of cholesterol, they are lipid soluble. Exactly. Amino acid based, they are water soluble, and because they are water soluble, they cannot cross the plasma membrane. While steroid hormones, they are lipid soluble, so they can cross the plasma membrane. Most hormones released by glands in our body are amino acid based, while gonadal and adrenocortical hormones are steroid hormones. Okay. Eicosanoids is, they don't classify it basically as hormones, but it's a hormone-like substance. It includes leukotrienes and prostaglandins. They are made of arachidonic acids. Leukotrienes and prostaglandins have their own mechanism and effect, but they don't classify them as hormones because they have a localized effect. Just like autocrines and paracrines, they are part of it. Okay, so who's going to read? Someone else? You.
Endocrine glands.
Yeah? A. Can you read it out? C. Okay, that's true. Can you tell me why A is wrong? Okay, just tell me why the others are wrong.
Endocrine is ductless.
Endocrine is ductless. Why is A wrong?
Because this is an exocrine.
Okay, as your colleague here said, they are ductless. What about B? Does endocrine glands release neurotransmitters?
No, it releases hormones.
Exactly. C is correct. D, do they include sebaceous glands and sweat glands? They don't. They are exocrine. Next. An answer? No? Okay.
B.
B. Can you read it out loud?
Insulin-like growth factors secreted by one cell and acting on neighboring cells to promote growth.
Okay. So why are others wrong? Why are others wrong?
Which one do you think is wrong? Tell me, I'll tell you why.
Okay, so basically, A is wrong because histamine affects the same mast cell. What's this? Autocrine. C, efferent proteins on the surface of one cell interact with F receptors on an adjacent cell. What's this? Juxtacrines. Prostaglandins that act on the same smooth Autocrines, exactly. So we're left with B. B is perfect. Okay. Now we're going to talk about lipid-soluble hormones and water-soluble hormones. You remember we talked about amino acid-based, steroidal-based, right? Okay. So lipid-soluble hormones basically consist of all steroidal hormones and which hormone? Thyroid. Sorry? And thyroid hormone. True. Thyroid hormone actually is an amino acid-based hormone, but it's lipid-soluble. It's the only exception. The sources of lipid-soluble hormones are adrenal cortex, gonads, and thyroid gland, while water-soluble are all other endocrine glands. They are stored in the secretory vesicles, the water-soluble. How do they transport in blood? Lipid-soluble, they are bound to plasma proteins, while water-soluble are not. Because water-soluble, they can pass through food. But lipid-soluble hormones, they can't. Half-life in the blood. Lipid-soluble hormones have a very long half-life, while water-soluble have a very short half-life. Do you guys know why?
Because the water soluble, they can be filtered by the kidney and
True, exactly. So water-soluble hormones, they are filtered quickly by the kidneys and are excreted, while lipid-soluble need to be metabolized by the liver and then excreted out of the body. That's why it stays a longer time in the blood. Half-life basically is the amount of time that it needs for a certain hormone to decrease to half its amount in the blood, to be degraded, to half of its amount. Location of receptors, I guess these two were mentioned in 16.3 and it's deleted for you guys, right? Okay. So basically what it says is that the locations of lipid-soluble hormones are in the cell itself, while water-soluble are on the plasma membrane. You guys think why?
Because the lipid-soluble hormones can cross the plasma membrane, while
Exactly.
water-soluble can't.
True, exactly. So that's why they're inside. And based on this, lipid-soluble activate genes inside the cell, while water-soluble need a second messenger pathway to conduct its effect. The concentration of hormones in the blood depends on the rate of the release and the rate of degradation of the hormone. Another question. I'm going to start choosing. Tiger over there. Give it a try, it's fine. The guy next to you. No, give it a try, it's fine.
A is 1,
A is 1.
B is 3, C is 2.
That's true. Okay, so here, there are a lot of hormone interaction types. A hormone can exert its effect independently. A hormone can exert its effect depending on another hormone. Two hormones can exert the same effect on the same cell and enhance the response. At the same time, two hormones can antagonize themselves. In the first example, the presence of thyroid hormone enhances the effects of growth hormone on tissue development and metabolism. Without adequate thyroid hormone levels, growth hormone's ability to stimulate growth and metabolic processes is significantly impaired. This is what we call permissiveness. That's because a certain hormone cannot exert its effect on a cell unless another hormone helps it out. Here, growth hormone needs thyroid hormone to enhance its response. And the second example, in the kidney, aldosterone promotes sodium retention and water conservation, while atrial natriuretic peptide directly opposes aldosterone by promoting sodium excretion, thus lowering blood volume pressure. Here, the two hormones are antagonizing each other, and this is what we call antagonism. And the third example, both cortisol and glucagon promote glucose production in the liver, but when released together during a stress response, the effect on glucose release is far greater than the sum of their individual effects. So each one of them, cortisol alone and glucagon alone, can increase glucose levels in the blood. But when they act together, they enhance the release of glucose. This is what we call synergism. Okay. Another question.
Which of the following endocrine glands secretes a hormone that is amino acid based but can cross the plasma membrane and has receptors inside the cells? Thyroid.
That's true. Now I hand it off to you.
Good afternoon, everyone. I'm Mohammed and Naya. I'm going to be explaining a small part about the types of stimuli and then continuing with the last part of the chapter. First of all, thank you for Naya for giving us an introduction. So the endocrine mainly is related to glands, and for each gland it secretes hormones, right? For this gland to be able to secrete any hormone, it should be stimulated first. Am I right? So what is this stimuli? We have three different types of stimuli. Okay, which are humoral, neural, hormonal. So from the name, what do you think hormonal is? Hormones. So this gland, in order for it to be able to secrete its hormone, there should be another hormone that acts on it. Okay? Anyone can give me an example?
Thyroid stimulating hormone.
Thyroid stimulating hormone. What does it stimulate? The thyroid gland. Okay, so this means the thyroid gland, in order for it to be able to secrete any of its hormones, it should be stimulated by thyroid stimulating hormone. Another type of stimuli is, what do we have? Neural. Neural isn't that common. We have an example here about the medulla of the adrenal gland. We're going to come to it later. We have a gland called adrenal gland. It has a medulla. This medulla is stimulated by a neural stimulus, but it's not that common. And lastly, we have humoral. Humoral means varying concentrations of either salts or ions. And basically, let's give an example to understand it better. We have a gland called parathyroid gland. This parathyroid gland secretes parathyroid hormone. Okay? What is the stimulus for it? It is varying concentrations of a specific ion. In the case of parathyroid gland, is calcium. So varying levels of calcium are going to stimulate the parathyroid gland in order for it to secrete the parathyroid hormone. Okay? So these are basically the three main types of stimuli. Okay, we have a question here. You can try, anyone can try, just reading. You don't have to answer correct. A 3-year-old boy is born without anterior lobe of pituitary gland. Which of the following mechanism controls the hormones released by this gland? Hormonal. Okay. Now, nervous system regulation. In general, let's say you have ACTH. I'm going to give an example because it's easier to understand with an example. ACTH stimulates the release of glucose. So normally, in a normal scenario, the negative feedback inhibition, you have elevated levels of glucose, they act back on the pituitary to stop releasing ACTH to bring down the glucose levels. Okay? This is in a normal scenario. Sometimes, during stress, for example, although we have already existing high levels of glucose, because we are in stress, we need even more levels of glucose. Now the hormones cannot sense that the body is in stress and we need more glucose. The hormones can only tell, okay, we have elevated glucose, we should stop. But we have nervous system modulation that overrides these inhibitory effects, so it keeps sending signals for the ACTH to keep releasing because we needed even more elevated levels of glucose. So this is a classic example of the nervous system modulations, because just understand in your mind that the hormones are more mechanical, they're more the effectors, but they don't have the brain, so they cannot think what is right and what is wrong. Okay? And that's it for my part right now. We're going to continue with the last part of the chapter. Okay.
let's start. Okay. So first of all, the pituitary gland, where it's placed, where it's situated.
Beside the hypothalamus?
Yes, but not exactly. So the pituitary gland is basically securely seated in the sella turcica. Sella turcica, it's a part of the siphonoid bone. You see this purple part? This is the sella turcica of the siphonoid bone, okay? So there, the pituitary gland is situated, okay? And the pituitary gland secretes 8 hormones. From the posterior pituitary and from the anterior pituitary, 2 from the posterior and 6 from the anterior. Okay. Here is a mind map or a concept map that summarizes it. As I said, 6 hormones from the anterior pituitary and 2 from the posterior pituitary. What are the hormones that are secreted by the posterior pituitary?
ADH and
Yes. And the other 6 hormones from the anterior?
Those hormones?
Yes.
Somatotropin? Luteinizing hormone?
Yes,
Follicular stimulating hormone?
exactly. It's fine. I'm going to be showing you a mnemonic that you're going to memorize easier. It's in the word flat pick, you're going to see it now. So basically, the main difference between the anterior and the posterior pituitary is that the posterior pituitary is not an actual endocrine gland. It's a neural tissue, okay? It has a direct communication with the hypothalamus, and it's basically a neural tissue, and it's acts as a storage area. So it's not secreting the hormone oxytocin and the Alnabhan hormone. Sorry, the antidiuretic hormone. It's only a storage area. Whether the anterior pituitary, it is a re-endocrine gland that's going to secrete the hormones from specific cells inside it, okay? And basically, the pituitary gland, it has a blood supply from the hypophyseal branches of the internal carotid arteries and the drainage into the dural sinuses, okay? Okay. Here we have the anatomy and all of these things. As an easy way to remember it, we said 2 hormones are secreted by the posterior pituitary, the oxytocin and the antidiuretic hormone. It's in the mnemonic SAT box. So S, supraoptic nuclear, D, AD, antidiuretic hormone. So remember that the supraoptic nuclear is secreting the antidiuretic hormone. And box, remember that paraventricular nuclear secreting the oxytocin. Okay? So nucleus is basically an collection of cell bodies in the CNS. This is a whole, this thing is a neuron, okay? The neuron has a cell body and an axon, okay? So the nucleus and the collection of cell bodies in the CNS, it's called nucleus. And the collection of axons in the CNS, it's called the tract, okay? So basically, we are having the nucleuses that are secreting the 2 hormones. They're going all down with the tract. This tract is the hypothalamus hypophyseal tract. And this area that's connecting between the hypothalamus and the posterior pituitary, it's called what? Infundibulum. Okay? And what's going to happen? When an action potential comes, the hormones are stored in the axon terminals. Okay? So when an action potential comes and fires the hypothalamic neuron, the action potential is going to go all down to the axon terminal and is going to secrete the hormones into the blood. Okay? That's it from here. Now for the anterior pituitary. The anterior pituitary is secreting 6 hormones. In the word flat pick, you ignore the E in the second word. We have follicle stimulating hormone, luteinizing hormone, adrenal hormone, thyroid stimulating hormone, prolactin, and growth hormone. Okay. The difference here that the anterior pituitary itself is going to secrete the hormone by itself in specific cells that we're going to talk about it. But there are also here hormones that are secreted by the hypothalamus, the releasing and the inhibiting hormone. Because when the body knows that, like, when should I secrete my hormones? By these. These are going to tell the anterior pituitary to secrete the hormones, the releasing and the inhibiting hormones. All of these releasing and inhibiting hormones are amino acid based. Okay? So here, these are going to tell the anterior pituitary when to release the hormones, and we have here this portal system, primary capillary bed, then it's going to drain into hypophyseal portal veins, then the secondary capillary plexus. So it's going to go anterior pituitary, going to secrete its hormones whenever an action potential goes to the hypothalamic neurons, and the releasing hormone are going to be secreted, either a releasing hormone or inhibiting hormone. If it was a releasing hormone, then it's going to tell the anterior pituitary to secrete its hormone. If it was an inhibitory, then it blocks the secretion, basically. Okay? And that's it from here. Okay. Who wants to answer this question? Come on, anyone.
C, neurosecretory cells.
Yes, that is correct. So let's eliminate the other aspects. Basically, it's asking which hormones used to transport hormones from the hypothalamus to the posterior pituitary gland. As I said, the posterior pituitary gland are the hormones that are secreted by are neurohormones. They are going to be secreted by neurosecretory cells. Why hypophyseal portal vein is wrong?
For the anterior.
Yes. And direct connection via gap junction, it has nothing to do with it. And the arterial that supplies basically again for the anterior. Exactly. Okay. Now we will be talking about the posterior pituitary hormones, the oxytocin and the antidiuretic hormones. Okay? So oxytocin has two important functions. What are those?
Childbirth and
Ejection of milk. It's important for the contraction of the uterus during childbirth and ejection of milk. Okay? So what's going to happen exactly? That during the last trimester of the pregnancy, oxytocin receptors are going to increase in the uterus. They're going to increase in the uterus, and they're going to cause stretch of the uterine cervix. Okay? And also during the end of pregnancy again, after the pregnancy, there's going to be ejection of the milk, and this ejection of the milk is stimulated by the suckling of the infant. Okay, it's not going to be stimulated otherwise until the baby suckles. Okay, so as I said here, the similarity of things are going to be two things: the stretching of the uterine cervix and the suckling of the infant. And it's inhibited by lack of appropriate neural stimuli. And the hypo or the hyposecretion is unknown. We don't know how it happens. And for the antidiuretic hormone, what is its main function? What does it do?
for water retention.
Exactly, for the water balance. So we don't want to dehydration, we don't want overload of water. So this one is going to balance the amount of the water. If it's balancing the amount of the water, then it's balancing the amount of the solutes as well. Okay? So what's going to happen? There are what was the name of the hormones? No. Let me check them. Okay, there are specific cells in these cells are hypothalamic neurons, okay? The specific hypothalamic neurons that are going to send an excitatory impulse whenever there is high amount of solutes in the blood. So whenever there is high amount of solutes in the blood, the antidiuretic hormone is going to be secreted. What does it do? It targets the kidney tubule cells, okay? It's going to take water from the urine and return it to the blood. By this, they are increasing the amount of the water in the blood and decreasing what? Solute concentration, exactly. Okay? So this is its function. It's preventing the dehydration and overload of the water. It's stimulated by impulses from the hypothalamic neuron in response to increased blood solute, as we said. Increased blood solute, low blood volume, low blood pressure. All of these are going to stimulate its secretion. And it's also stimulated by pain and drugs such as nicotine, morphine, barbiturates. All of these are going to also stimulate its secretion. It's inhibited by what basically? If we drink what? No, that's a disease. Like what's going to happen?
For the ADHs?
Yes, what's inhibited?
Alcohol.
Alcohol and hydration. A huge amount of water is going to inhibit it. Okay? Okay, who wants to answer this question? Wrong. Who wants to answer here? Yes, because as we said, the posterior pituitary hormones are not secreted from the posterior pituitary itself. They are secreted by the hypothalamus, so they're going to go down and be stored in the posterior pituitary. So it is the hypothalamus. Here we're having a homeostatic imbalance. What's going to happen? We said for the oxytocin it's unknown, but for the antidiuretic hormones, we have either deficiency, hyposecretion, or hypersecretion. So in the case of hyposecretion or antidiuretic hormone deficiency, what's the condition? What's called? Yes, diabetes insipidus. Okay. So what's going to happen in this condition that you don't have enough amount of the antidiuretic hormone, so intense thirst and huge urine output and all of these conditions. Is it a big problem? Is it a risk? Is it risky condition?
Yes.
When?
It's very low mass ADH secreted, so water volume will go, blood volume will decrease.
Yes, but it's not that risky when the thirst center is operating normally, because the person is losing water and basically losing a lot of amount of urine, so they're gonna basically hydrate themselves. So if they hydrated themselves, it's normal, nothing gonna happen. When this condition is going to be dangerous, when they are unconscious, when they're comatose. Otherwise, it's not serious. And when it happens, basically, if there's a pituitary tumor, if there's trauma to the hypothalamus or the posterior pituitary, okay. Moving to the hypersecretion, what is the condition called? Hypersecretion of antidiuretic hormone. Yes. It's called syndrome of inappropriate antidiuretic hormone secretion. So it happens in the adult and children. When it's going to happen in the children's?
Meningitis.
Yes. And in the adult, neurosurgery, hypothalamic injury, also after partial anesthesia, and the other conditions will happen in the cancer, is particularly lung cancer. Why? Why do you think it's happening in the cancer?
Because ADH secreted triangulate hypersecreted or hypersecreted.
The cancer cells are an extra source for the antidiuretic hormone. That's why it's causing hypersecretion, okay? So what's going to happen here, opposite to what's happening in the hyposecretion, you're going to have retention of fluid, you're going to have brain edema, weight gain, high blood pressure, high blood volume, and all those things, okay? Who wants to answer this question? Come on. Yes.
D, ADH levels will decrease.
No. Yes. Yes, they will increase. Because a person that's working outside for a long time and they didn't drink enough amount of water, so they're dehydrated. So if they're dehydrated, the blood volume is low and the sodium concentrations are high. So what did we say? If the sodium concentration is high, what's going to be secreted? The antidiuretic hormone. Okay. So antidiuretic level should increase to basically take the water from the urine to the blood. Okay. Who wants to answer this question? Who wants to answer it? Yes.
D, decrease potassium excretion.
No. Dilation of blood vessels?
No, C.
No. Naturally, A. I'll be explaining to now. We'll be enumerating the options. Has the 70-year-old boy and so on, it's having frequent urination and always feeling thirsty. Okay? The doctor diagnosed this case as hyposecretion of a hormone from the posterior pituitary gland. What is this hormone? Yes. And there's a hormone. There's hyposecretion of it. So what did we say? If there's hyposecretion of the antidiuretic hormone, what's going to happen? Exactly. Exactly. So if there's increase in the blood volume, increase in the blood pressure. You didn't take this yet, but you're going to know it in the blood result chapter sooner or later. Okay. Now moving to the anterior pituitary hormones. As I said, we have 6 hormones, starting with the growth hormone. Okay. Growth hormone are secreted by cells in the anterior pituitary called the somatotropic cells. Okay? The growth hormone has another name, which is, what is the other name of the growth hormone? Somatotropin, from the name of the cells that are secreting it. Okay? So growth hormone also called somatotropin. And growth hormone has a direct effect, a direct metabolic action, and an indirect growth action. Tamam? So what's going to happen in the direct metabolic action? It's going to increase the blood glucose level. How it's doing that? Hyperglycemia is going to happen by two things. It's going to decrease the uptake of the glucose by the cells, and it's going to increase the glycogen breakdown in the liver. Thus, you're going to have hyperglycemia or high blood glucose level. And the other condition that's basically is going to increase the fat breakdown, all those things in the metabolic actions, and increase the amino acid uptake, and all those things. In the indirect action, it's going to act by the insulin-like growth factors. Insulin-like growth factors are going to be released by the liver, bone, and the skeletal muscle. If they're released by the liver, is it a hormone? Do we call it hormone or autocrine or paracrine? What do we call it? If it's secreted by the liver. Insulin-like growth factors. Yes. As if it's secreted by the bones or the skeletal muscle, we call it paracrine. Exactly. Because it's having a direct effect on the liver. So what's going to happen here? It's going to do increased skeletal growth, increased cartilage growth, and all those things. So it has an indirect growth action. And moving to the regulation of the secretion, we're having two hormones for the growth hormone. It's the only one that have a releasing and an inhibitory one, okay? So growth hormone releasing hormone and growth hormone inhibitory hormone. It's also called somatostatin. We're gonna now know in the next slide how it's working. And we have something called tropic hormones. What are those? Yes.
I want to question.
Yes.
When it's released by the liver, is it autocrine or paracrine?
A hormone.
Hormone.
Yes. And we have something called tropic hormones. What are those tropic hormones? What they do? Exactly. The tropic hormones are going to stimulate other endocrine glands. Okay? We have 4 of the anterior pituitary hormones are tropic hormones. In the mnemonic, flat. Do you know what are those hormones now? Yes. So those hormones, tropic hormones, means that they are going to activate other endocrine glands to secrete their hormone. For example, in the thyroid releasing hormone, the thyroid releasing hormone is going to be secreted from the hypothalamus, and it's going to activate the thyrotropic cells to secrete thyroid stimulating hormone from the anterior pituitary. Okay? And then the anterior pituitary, by releasing the thyroid stimulating hormone, is going to activate the thyroid gland to secrete what? The thyroid hormone itself. That's why it's a tropic hormone, because it helps the thyroid gland to secrete hormone. Okay. Who wants to answer this question? What is the answer? Yes?
I think C.
Yes, it is C. So it's asking about what's most likely effect of the excess growth hormone in this patient. If you're having excess growth hormone, it's going to do what? It's going to, is it going to increase the glucose uptake and storage in the tissue? Yes or no? No. Let me show you the answer. Okay, it is C. Increase the breakdown of the glycogen in the liver, leading to hypoglycemia. This could be correct in one condition. How? If we change one word.
Hypoglycemia to hyperglycemia.
Exactly. And the last option, increase production of insulin growth factor in the pancreas. Does it increase in the pancreas?
No.
Yes, exactly. That's why that's wrong. This one should be easy. Yes?
Mobilization.
fat and conserve glucose?
Yeah, it's A. My bad. It is A.
With the job,
The direct action of the growth hormone that's going to metabolize fat and conserve glucose. All the others are what? Indirect. Moving to the homeostatic imbalance of the growth hormone, we have again hypersecretion, but in the children and in the adults, okay? So if we have hypersecretion in the children, what's going to happen? Yes. Because it's basically before the closure of the epiphyseal plates. So it's allowing the long bone growth. That's why this person on the left side is really having a tall height. It's like 1.2 meter or so on. And if we have a hyposecretion in the children, what's going to happen? Dwarfism, exactly. They're going to be short like this. And in the adults, if you have hypo and hypersecretion, what's going to happen? Yes, in the adults, you're going to have acromegaly because it's after the epiphyseal plate closure. So you're going to have long hands, long feet, long face, and so on. And hyposecretion doesn't really affect them. It's خلاص يعني they're already. Okay. We have stimulatory and inhibitory again for the growth hormone. So we said we are having growth hormone releasing hormone and growth hormone inhibitory hormone. So the growth hormone is stimulated by the growth hormone releasing hormone and also by what stimulated? What do you think could stimulate the growth hormone to be released? Yeah, it could be. I said the most time that the growth hormone, like it peaks at level when it is at night before sleeping. So that's why deep sleep stimulates growth hormone. And if you're having if you're having hypoglycemia, it's going to basically stimulate the growth hormone because growth hormone is going to do what? Hyperglycemia. So when you have hypoglycemia, it's going to be secreted to balance that out. And also when you have increased blood in the blood level of amino acids and low level of fatty acids and exercise and stressors and all those things. And it's going to be inhibited by the growth, by the feedback inhibition by two things. What are those? The growth hormone itself and insulin-like growth factor. If you're having both of these really high, it's going to do a feedback inhibition to the growth hormone and prevent its release. And if you're having hyperglycemia, because again, what's the job of the growth hormone? It's going to increase the blood glucose level. So if it's increased double, it's not normal. So we balance that out by inhibiting it. Okay? And all the other conditions similar. The hyperlipidemia, obesity, and so on. And also the decreased growth hormone releasing hormone release is going to do what? Inhibit. What do you think the answer? Not A, because it's 16-year-old. So it's still the epiphyseal plate, they didn't close. It's before the pituitary, puberty, sorry, it's before the puberty. So they're gonna have gigantism. Okay? That's the reason. It's 16-year-old and it's showing basically normal body proportions. What does that mean? Normal body proportions. It doesn't have long hand and feet. Okay? And report excessive sweating, joint pain, increased shoe size, and so on, and excessive height. So it's having excessive height and gigantism. Okay? Now moving to the other hormones from the anterior to T, thyroid stimulating hormone and the adrenocorticotropic hormone. Okay. So what stimulates the release of the thyroid stimulating hormone? Here,
Thyroid stimulating hormone release hormone.
Exactly. Thyrotropin, it's called thyrotropin releasing hormone. And also in infants, indirectly by cold temperature, because basically the thyroid hormone later on you're going to learn that it's increasing the metabolic rate, it's increasing the heat. So if there's cold in the infants, it's also going to be stimulated. And it's inhibited, again, by the feedback inhibition. If you're having a lot of thyroid hormone, it's going to go back and feedback inhibit the release of the thyroid stimulating hormone. It's also inhibited by the growth hormone inhibitory hormone. So the growth hormone inhibitory hormone inhibits what? Two things.
TCH and G.
Exactly. And you're having the conditions that are happening, the hypothyroidism and the hyperthyroidism. My friend will be explaining that. And we have the adrenocorticotropic hormone. This adrenocorticotropic hormone is going to basically stimulate the hormones in the adrenal cortex, the glucocorticoids, to be secreted. Okay? This is its job. So what's stimulated? Again, we are having releasing hormone, inhibitory hormone. So what's
Releasing hormone.
releasing hormone? It's called corticotropin releasing hormone. Okay? And also fever stimulated with hypoglycemia. Like which condition? Another hormone was also stimulated by hypoglycemia. Yes, growth hormone. And it's inhibited again by feedback inhibition of the glucocorticoids. Glucocorticoids are secreted by the adrenal cortex, and those ones, if there's a huge amount of them, they're going to inhibit the secretion of the adrenocorticotropic hormone. Okay? And again, the conditions, my friend are going to be explaining them. Who wants to answer? Yes?
And totally tumor causing overproduction.
So we're having a person that is cold intolerance, dry skin. His blood tests show low T3 and T4 levels with high thyroid stimulating hormone. What is the most likely case of the hypothyroidism? Pituitary tumor causing overproduction of the TCH? No. If there's overproduction of the TCH, well, you have hypothyroidism or hyperthyroidism? Hyper. The second one is correct. Malfunction of the hypothalamus affecting TCH release. Does the hypothalamus secrete its TCH? It's secreted by anterior pituitary. So this is also wrong. Thyroid gland filler with compensatory high thyroid stimulating hormone? No, again, so it's now moving to the gonadotropins, which are two, follicle stimulating hormone and the luteinizing hormone. The follicle stimulating hormone, its job is simple. It's going to stimulate the production of the gametes, sperm and the eggs. But the luteinizing hormone, it has several other functions. In females, it works with the FSH to cause an egg containing ovarian follicle to mature. Also in the females, it's going to trigger ovulation. Okay? And in the males, it's going to stimulate specific cells called interstitial cell to produce the hormone testosterone. So here we have the stimulatory and the inhibitory and all of those things. For the follicle stimulating hormone, it's stimulated by what? Gonadotropins hormone, exactly. And it's inhibited again by feedback inhibition of the inhibin and estrogen in females and testosterone in males. What about the luteinizing hormone? What's stimulated and what inhibits it? Again, yeah, stimulated by the gonadotropic hormone, but the difference here that the feedback inhibition in the females, it's by estrogen and progesterone, not estrogen and inhibin. And in the males, it's the same, testosterone, okay? And we have the prolactin. Okay. We have here the prolactin. What is the function of prolactin? What's the main function of the prolactin hormone? Production of milk. What was the hormone that's ejecting the milk? Oxytocin. So prolactin, it has an important function in basically production of the milk. In the males, it's unknown what it does, but in the females, production of the milk. And here, the situation for prolactin is a bit different. Why? It's having a prolactin inhibitory hormone instead of a releasing hormone. This is the only one to have an inhibitory hormone. Tamam? It's stimulated by decrease of the inhibitory hormone. And the inhibitory hormone, prolactin inhibitory hormone, has another name called?
Dopamine.
Yes. So it's stimulated by decrease of the prolactin inhibitory hormone. And also stimulated by estrogen and by birth control pills, and breastfeeding and the dopamine blocking drugs. Okay, inhibited by what? Yes, prolactin inhibition, which is dopamine. Tamam? This is a matching question. You're gonna have matching, I guess, in your quiz and in the lecture as well. Final. Yes. Yes.
One was
A.
C. One was C.
You say C.
It's
What? How are we supposed to
the answer.
Wait. I'm gonna show you. It's A. Going one by one. Hormone that causes uterine contraction during childbirth. What is it? Oxytocin. Going to the second one. Stimulates secretion of non-stress steroid hormones. Adrenocorticotropic hormone. Third one. Inhibited by advocate hydration and alcohol. And diuretic hormone. If there was hypersecretion of this hormone, it does dwarfism. Yes. So, in the same order, it's A. Okay. Now moving to the last thing about the prolactin. If it was hyposecreted and hypersecreted. So what's going to happen if there was hyposecretion of prolactin? Yes. For the hyposecretion, it's not a big problem. It's only a problem for the women that are basically breastfeeding. Otherwise, it's not really common. What about the hypersecretion? Yes, exactly. It will cause a condition called galactorrhea, which is excessive milk secretion, and it's the most common anterior pituitary, it's the most frequent abnormality of the anterior pituitary tumor, and it might also be caused by medications such as Haldol and Eldovit. Haldol is going to do what? It's used in the management of psychosis. It blocks the dopamine receptor. If you block the dopamine receptor, what's going to happen? Yes, we don't have prolactin inhibitory hormone, so there's going to be a huge surge of what? The prolactin. So, hyperprolactinemia. And the other medication is Eldovit. It's an antihypertensive medication. This one decreases the dopamine level in the brain, but that one blocks the dopamine receptors. Okay? And another question, I guess. What do you think is the answer? Does anyone want to answer?
Excessive prolactin secretion.
It's correct. Okay. Okay, so it's asking about what? There is normal level of gonadotropins, but there is galactorrhea, which is hyperprolactin, hyperprolactinemia, and so on. Increased dopamine production, inhibiting prolactin release. Does increased dopamine production inhibit prolactin release? It's correct, but not in the hyperprolactinemia. Okay? And excessive prolactin secretion due to pituitary tumor, this one is correct. Decreased estrogen level, causing elevated prolactin level. Is this correct? Decreased estrogen will elevate prolactin?
No.
It stimulates it, right? If there's a lot of estrogen, then the prolactin will be stimulated. Increased gonadotropin level leading to ovarian dysfunction? Also no. The last thing that I want to mention, that when you're having a tumor, it's mostly, so the tumor has two classifications. If the tumor was, let's say, an adenoma, an internal tumor, a secretory tumor, it's mostly going to cause hypersecretion of the hormones. If the tumor was outside, like if the tumor was blocking the connection between the hypothalamus and the pituitary gland, like it's blocking the infundibulum or basically the tract that's there, or the veins and the arteries and the anterior, in that case, it's mostly going to be hyposecretion, okay? Because there's no hormone secreted. Except one thing, hyposecretion of all the hormones, but hypersecretion of prolactin. Because prolactin is the only one that has what? Inhibiting hormone, prolactin inhibiting hormone. And for the hyposecretion, mostly, it's what? Trauma. when you have a trauma in the question, of course, focus on the other things. But when you have a trauma in the question, it's mostly going to be a hyposecretion of that hormone. Okay? And that's it.
I have a question. For the last question, why the answer A was wrong? Like if we increase the dopamine.
Show me the question. I don't have it.
I don't have it. Yes. Like if we increase the problem here shouldn't be because we block the dopamine receptors. So if we increase the, shouldn't it inhibit the prolactin release?
What is the problem here? Saying you're having galacturia, which is hyperprolactin level. Hyperprolactinemia, okay? So you're having this elevated prolactin level and normal level of gonadotropins and those things, okay? So what's the most likely diagnosis of your symptom? Increased dopamine production, inhibiting prolactin release. If the dopamine was increased, what's gonna happen? Inhibits what?
The prolactin.
Yes.
Yeah. So why it's wrong?
I'm
You
gonna
want to
explain.
inhibit. Okay, maybe because it's not the treatment. Yes, it's the cause of the symptom. If it was treatment, it would be A.
I'll explain it for you here. But you can continue.
Okay, so hello everyone, I'm back. I'll be explaining thyroid and parathyroid. Parathyroid gland. Okay, so let's first of all start with the anatomy of the thyroid. So thyroid is a gland that is present on our trachea. It's inferior to the larynx, and it engulfs the trachea like this. Okay, it looks like a butterfly. It's formed of two lobes, and there is a connecting mass here between called the isthmus of the thyroid gland. It's it's richly vascularized with the inferior and the superior thyroid arteries. That's why any surgery there could be very bloody. A lot of blood is going to get out. Endocrine thyroid gland is the only pure endocrine gland that we have in our body. Do you guys know why? Okay. So basically, this thyroid gland is purely formed of endocrine tissue. There is no any other type of tissue in it. It's formed of follicles, and between these follicles there is an epithelium. These follicles are basically formed of follicular cells at the periphery. It's like a ball, and in the middle there is a lumen that stores the colloid. Okay? These follicular cells are either cuboidal or squamous cells. They are the ones that produce or secrete this colloid into the lumen. Colloid basically is the inactive form of the thyroid hormone. Between these follicles, we have here parafollicular cells, or we can call them C cells. They produce or secrete calcitonin. They form a protrusion in the follicular epithelium between the follicles. Okay. So first of all, thyroid hormone, thyroid gland produces two types of hormones, T3 and T4. Produces T4 in a very large amount, but the tissues of our body uses T3 mostly. So they take T4 and they convert it into T3, and then they use T3 because T3 is more active than T4. T4 is basically the thyroxine, and T3 is the triiodothyroxine. What does thyroid hormone effect does to our body? Thyroid hormone is the major hormone that controls our metabolic rate, and thus it increases our basal metabolic rate and our body heat production. How does it do that? By stimulating the transcription of genes that are responsible of glucose oxidation. You guys took glycolysis, right? In glycolysis, it produces ATP. Later on, pyruvate is transferred into acetyl-CoA and then gets into the TCA cycle, and then it produces more ATP. So ATP basically is the source of energy, and the main thing that helps in controlling the transcription of glucose oxidation is thyroid hormone. And that's why we call it its calorogenic effect, because it helps generate heat in our body. Second of all, it helps in regulating tissue growth and maturation of our skeletal development and our maturation of the nervous system. And it also helps in the maturation of our reproductive capabilities. Lastly but not least, it helps in regulating our blood pressure by increasing androgenic receptors. When we increase androgenic receptors, these receptors are going to respond to epinephrine and norepinephrine, and thus epinephrine and norepinephrine are going to have their effect on increasing blood pressure or maintaining it by vasoconstriction, vasodilation mechanism. Okay. TCH is produced by the anterior, by the anterior pituitary. What does it do? It binds to receptors on the follicular cells and stimulates or triggers these receptors or the receptors on these cells so that the cell can produce thyroid hormone or thyroglobulin colloid. Once it does that, first of all, this mechanism works in two-step response. The first response is that it will help the lumen to release the colloid that's inside of it, and it will help the follicular cells to restore these colloid that's being released. Okay? TCH pattern, basically, it peaks in your sleep, and it's the lowest when you wake up, and the same pattern follows thyroid hormone. And there's some medications that can help in reducing thyroid hormone, for example, lithium. How do we diagnose the level of thyroid hormone in our blood? We measure the blood levels of T3, T4, and TSH. Okay, so how does thyroid hormone is synthesized? First of all, the first step is that the ribosomes on the endoplasmic reticulum are going to produce thyroglobulin colloid. When this thyroglobulin colloid is going to go to Golgi apparatus so that it will get modified and suitable to be released to our body by binding sugar molecules, and then it will be stored in transporter vesicles and then released into the lumen. That's the first step. The second step, the iodide in our blood is going to be actively transported into the follicular cells. Once it gets in, it will get released into the lumen through facilitated diffusion. Alright? The third step, iodide can't attach to thyroglobulin in that form. We need to oxidize it. We need to transform it into iodine. Exactly. We need to transform it into iodine. This happens at the border of the follicular cells and the lumen. Fourth of all, iodine, the oxidized form, iodine, is being attached to the tyrosine that is on the thyroglobulin colloid molecule. This happens by peroxidase enzymes. This also happens at the junction. This is going to result in forming two molecules, either DIT or MIT, diiodotyrosine or monoiodotyrosine. The fifth step is that these iodinated tyrosines are going to be linked together by enzymes in the colloid. They're going to form either T3 or T4, but it will never form T2 because T2 cannot be used up by our body. T4 is basically two DIT molecules. T3 is one DIT and one MIT molecule. Then this thyroglobulin colloid, along with the iodinated tyrosines and T3 and T4, is going to be endocytosed and combined with lysosomes. Okay? Why do we need to combine them with lysosomes? Because lysosomal enzymes are going to separate the colloid, which is the yellow part, from the DITs and the T3 and the T4. Okay? And then it's going to be diffused into our blood vessels. What happens to T3 and T4 in our blood? Later on, these are going to bind to special proteins, because you remember what we said about thyroid hormone? It is lipid soluble. It cannot pass freely in the blood. It needs to be bound to plasma proteins. These plasma proteins are called thyroxine binding globulins. These are going to carry these thyroid hormones, T4 and T3, into their target cells. Alright? Then later on most cells have enzymes that are going to convert T4 to T3 because T3 is more active, and sometimes they can just use up T4. Okay. How is thyroid hormone regulated? Thyroid hormone is regulated through a negative feedback loop. Okay? How does it do that? When thyroid hormone levels are increased in the blood, it's going to send signals to the anterior pituitary and the hypothalamus to stop releasing TSH and TRH. We don't need them. We have a lot of TH now.
It oppositely happens when thyroid hormones are in low levels. It's going to send signals to the anterior pituitary and the hypothalamus to release more TRH and TSH so that it can release more thyroid hormone. There are also some other mechanisms that can also inhibit the TSH release, like growth hormone inhibiting hormone, dopamine, glucocorticoids, and when we have a lot of iodine, excessive iodine in our blood or iodide, yes?
Does that mean that it's stimulated and inhibited humorally or hormonally? Hormonally, right?
Hormonally. Okay. So when we have a lot of iodine in our blood, it's going to inhibit TH, not TSH. Focus on this point. Okay? We also have infants. Infants, when they get cold, this cold is going to stimulate the hypothalamus to stop releasing TRH. Okay? And to release more TRH. And thus it will release more TRH, more TSH, more thyroid hormone, so that they can generate heat and maintain their body temperature. Okay. What are some homeostatic imbalances? Just take it as a rule. Every gland has two types of imbalances: hypersecretion and hyposecretion. Here, myxedema is the form of hyposecretion of thyroid hormone. Is it clear? Do you want me to? Okay. Alright. So every homeostatic imbalance in this lesson have the cause, the signs and symptoms, the main complication, and the treatment. Okay? Here, what causes this? It could either be because of a lack of iodine, for example, and some other causes. This is full-blown hypothyroid syndrome. It's characterized by having a low metabolic rate, because we know thyroid hormone maintains metabolic rate, so we don't have thyroid hormone, low metabolic rate. Feeling chilled, cold, puffy eyes, edema, thick dry skin, lethargy, mental sluggishness, and constipation. Goiter is the severe form of hypothyroidism. When does it happen? When there is a lack of iodine. It's releasing colloid, but there's no iodine. How am I going to release this to the blood? There's no thyroid hormone anymore. This happens, yes, because of this. Pituitary gland, it's going to secrete an increasing amount of TSH, but there is a failed attempt to stimulate the thyroid. I can't release thyroid anymore. How can I treat this? It's very simple. I don't have iodine. Give me iodine. That's it. It's finished. Also, we can use hormone replacement therapy. There's another form of hypothyroidism that's congenital. This happens either because there was a poor development of the thyroid gland during pregnancy, due to maternal complications, or due to pituitary problems. How does it happen? How is it characterized in infants? A poor cry, poor feeding, constipation, prolonged jaundice. How can we treat this? Through oral thyroid. And this therapy needs to be maintained throughout life, because it's in the thyroid. It's not like something is missing and giving it back. Then we have hyperthyroidism. Hyperthyroidism is the hypersecretion of thyroid. This is called Graves' disease. Graves' disease is an autoimmune disease. This is where the body is going to secrete autoantibodies. Normally, an autoimmune disease happens when a body secretes autoantibodies and is going to attack the cells of our body. Here, what it does, it doesn't attack. It mimics the action of TSH. When it mimics the action of TSH, that means I'm getting the stimulus I need. I'm going to produce thyroid, right? So it's going to produce more thyroid, and it will cause hypersecretion of thyroid. It's characterized by elevated metabolic rate, sweating, rapid or irregular heartbeat, nervousness, weight loss, and exophthalmos. That's the main symptom of this disease, exophthalmos. It happens because fluid is going to fill behind the eye, and when it's going to fill, it's going to fibrose, it's going to fill with fats, it's going to protrude the eyes forward. So this is a characteristic of Graves' disease. What's the treatment? Remove the thyroid. Simple. Or we can give radioactive iodine. This radioactive iodine is going to attack the hyperactive cells and it's going to stop them from producing more thyroid. Okay?
You raised your hand? Can you read the question?
46-year-old obese female came to your clinic with a very low body temperature. She is always feeling cold, her skin is very dry, and she has poor muscle tone. Which of the following is the best treatment for her condition? A.
Why do you think it's A?
I just remember some iron. You said iron.
Iron?
Yeah.
Remember, what is the mineral that we need? Is it iron? Okay, it's fine. Yes.
B, oral thyroxine.
That's true. This, it's a bit tricky, but it's not iron. What you need for thyroid is iodine. They're similar to each other, so you can get tricked. So you need to focus in the choices. It is oral thyroxine. Here she's feeling cold. Her skin is very dry. She has poor muscle tone. What is the diagnosis here?
Graves' disease.
Hypothyroidism. Okay? So yes, we give her oral thyroxine as it can, I can relate for it. If it was iodine-rich diet, it would have been correct. Okay? Alright. Another question. Who's gonna answer? You read the question and then
A 41-year-old male was diagnosed with a case of Graves' disease. Which of the following hormones levels will be increased in his blood? A. Thyroid-stimulating hormone.
No. Yes. B. It is B. That's true. Why is A wrong? Is that because we have a lot of thyroid hormone. Remember, the regulation of TH is going to have a negative feedback and is going to decrease. No need for TSH anymore, right? So we don't need TSH anymore, so it's not TSH. Yes?
Yeah, but like, how do we know if it's TSH or just TH?
Okay, so basically here, it's Graves' disease. So we have a lot of thyroid hormone. And I mentioned earlier that thyroid hormone has a negative feedback loop, right? So when it's high in the blood, it's going to send signals to the hypothalamus and the anterior to stop producing TSH. I don't need TSH. I'm good enough, right? So that's why TSH is Osama low in the blood.
Oh, so it's not even produced.
It's not produced. There's a lot of TH. Okay. Yes. Another one. Yes.
B.
Can you read the question?
Which of the following mechanisms provides a functional thyroid hormone? Iodide is attached to the thyroxine.
Is iodide attached to the thyroxine? What form is attached? Yes.
D. Lysosomal breakdown of aldosterone.
No.
Is it A?
It is A. That's true. Remember, iodide is converted to iodine. Iodide cannot be attached to tyrosine. It's not in the oxidized. You need to get oxidized first and then to be attached. Okay? Why is D wrong? Is that lysosomes do not break down iodotyrosine. They just separate the thyroid globulins from the T3 and T4. That's it. And if you're going to break down iodotyrosine, what's شو الفايدة؟ ما استفدنا شيء. You just lost it. You built it and then you broke it down. Did you get it?
Yeah.
Okay. Now calcitonin is produced by parafollicular cells, which are C cells, that are also in the thyroid gland. It's released in response to high calcium level. Okay? طبعا if it's there or not, it's not a big deal يعني. But it can be used in Paget disease and osteoporosis. What does it do is that it inhibits osteoclast activity. Osteoclasts are bony cells that are, they just eat up the bone and release calcium to the blood. So I have a lot of calcium, I don't need you to eat up the bone, خلاص. Just sit aside. So it inhibits the osteoclast activity and it also stimulates the calcium uptake into the bony matrix.
Alright? Okay. Now the parathyroid gland. The parathyroid gland is a very tiny gland that's present around the thyroid, either on the posterior part, or it can even be in your thorax. It's fine. There could be a lot of, it can vary from 4 to 8 to 6. It's fine. It's characterized by having two types of cells, parathyroid cells and occipital cells. Occipital cells are the least amount. They don't have a clear function. They're just there. They didn't know yet. Parathyroid cells are the cells that release the parathyroid hormone or the parathyroid. This hormone is the major hormone to maintain the calcium homeostatic, the calcium balance in our blood. It's the main hormone to carry. Yani calcitonin is fine if it's there or not, but the main one that you need is parathyroid. Okay? What does the parathyroid hormone effect does? It has two direct effects and it has one indirect effect. The first direct effect is that it's going to stimulate the osteoclasts to eat up the bone and eat up the bony cells and release calcium and phosphate into the blood. That's our first step. It increases the calcium level in the blood. The second direct effect is that it increases the calcium reabsorption from the kidney's tubules. So it tells the kidney, I need you to reabsorb for me calcium, I need calcium in the blood now. That's the second direct effect. The third effect is indirect. What it does is that for calcium to be absorbed from our intestine, it needs vitamin D3. Vitamin D3 is the active form of vitamin D. Now I have vitamin D, I need it to get activated. That's what parathyroid hormone does. It activates vitamin D to its active form, which is vitamin D3, or the calcitriol, or 1,25-dihydroxycholecalciferol, in the kidneys, and then it helps the calcium to be absorbed from the intestine. Alright? Now here comes the homeostatic imbalance. We have hyperparathyroidism, we have hyperparathyroidism. Imagine with me, if there's a lot of parathyroid hormone, what will happen? The main thing that will happen.
Calcium.
Increased calcium. That's the first thing that's going to happen. Hypercalcemia. A lot of calcium is going to be there. This can happen because of a parathyroid gland tumor. As Hosna mentioned earlier, if the tumor is in the gland itself, it's going to cause an increase in the secretion of this gland's hormone. So here, if there's a tumor in the parathyroid gland, it will cause a hyperparathyroidism. What effect does it have on the bone? If I'm having a lot of calcium and a lot of parathyroid hormone, I'm telling it to eat up the bone. What will happen to the bone? Low bone density, exactly. Sorry?
Osteoporosis.
Osteoporosis could be, yeah. Okay. So this will cause softening and deformity of the bones, and here these mineral cells that are being released into the blood are going to be replaced with fibrous tissue. Okay? There is also a severe form of hyperparathyroidism called osteitis fibrosa cystica. That's when the bones are so eaten that it looks like a moth-eaten appearance on an X-ray. Okay? Okay, hypercalcemia. What will happen if hypercalcemia happens in the blood? We're going to have a depression of the nervous system. I will have abnormal reflexes in our body, weak skeletal muscles, and because there's a lot of calcium in the blood, it's going through the kidney tubules. So if I'm going to have a lot of calcium, it's going to block up the kidney tubules. It's going to build up and form stones, which are called kidney stones. Then it also can go and deposit in your soft tissue in your body. It's going to cause calcium deposits in your tissues all around your body if we have a lot of calcium. Okay. Hypoparathyroidism. Hypoparathyroidism happens either due to a trauma to the gland or due to a removal during thyroid surgery. They remove the parathyroid along with it. So I will have hyposecretion of the parathyroid hormone. What it will have an effect?
Calcemia.
Hypocalcemia. Hypocalcemia will cause an increased neural excitability, so I have tingling sensation, tetanies, which are muscle twitches that we can't control, convulsions, and yeah. If it is untreated, because of this, it can cause respiratory paralysis, and it will end up in death.
a 10-year-old boy having a goiter was surgically treated by an experienced surgeon. Which of the following best describe the reason for his death? Hypocalcemia.
That's true. Okay. So why do you think it's hypocalcemia?
Because severe cases of hypocalcemia can lead to death.
Exactly. So there's another clue is that
Inexperienced.
an unexperienced surgeon, so remove the parathyroid along with the thyroid, so there is hypocalcemia. Clear? Okay. I don't know.
Which of the following hormones commonly increases in the plasma of older individuals due to inadequate dietary intake of calcium? D. Calcitonin.
Calcitonin? What do you think?
Parathyroid hormone.
Yes, it's parathyroid hormone. Why did you say calcitonin? Let's elaborate on it.
Because inadequate take of calcium, which may enhance calcitonin to like eat away from the bones.
Okay. Here, you're having inadequate dietary intake of calcium. So what's the level of calcium in the blood?
Low.
It's low. So if you're having low calcitonin, what's the function of calcitonin? It decreases. It comes in response to high calcium intake, high calcium in the blood. So what calcitonin does is that it inhibits osteoclast activity. So it stops because I have enough calcium. But here you have the total opposite. Calcium in the blood is low, so you need parathyroid. Is it clear? This is easy. Yes. B. That's true. So a 37-year-old patient diagnosed with hyperparathyroidism, which of the following could be seen in this patient? Kidney stones. Hyperparathyroid. Why is this wrong? These two are not related to the case at all. Hypercalcified bones, that means I have a lot of calcium in the bone. So is it related to hyperparathyroidism? That's the total opposite. I'm going to release calcium. Okay, last one. Can you read the question?
Mr. Safwan makes an appointment to see his doctor to look at his abdominal area. Tests and x-rays reveal kidney stones as well as fragile bones. Further questioning reveals a medical history of abnormal reflexes and weakness. What is the most probable diagnosis of Safwan's problem? Hyperparathyroidism.
That's true. Okay, so why did we call it hyperparathyroidism? Because we have kidney stones, we have fragile bones, we have abnormal reflexes and weakness. They're all signs of a high calcium in the blood, which is caused by hyperparathyroidism. That was for my part.
Okay. Two things. First thing is, how many of you have no idea about this part of the chapter? Okay, so the rest of you, you've at least attended the lecture or read it. And the second thing is, I feel like we need a break, but we're very short on time, so just take 2 minutes, take a deep breath, drink some water, and then we'll start. Because this part is a bit tricky. So just take 2 minutes, and we'll continue. Everyone, the adrenal glands, or we call them the suprarenal glands. Supra means above, renal means kidneys. So they're located right above the kidneys. And we have two kidneys, so we have two adrenal glands, but they have the same function. The secretions of these glands are mainly towards helping us cope with stress, whether that be short-term stress or long-term stress. The general structure of the adrenal gland, we have an outer cortex and an inner medulla. The cortex is divided into three main layers. okay, or zones. The first one is the zona glomerulosa. Glomerulosa means clusters, so the cells are arranged in clusters, and this layer is mainly responsible for secreting mineralocorticoids. Okay, mineralo, you can guess that it's related to minerals and salts and ions. Corticoids because it's from the adrenal cortex, and the OH because it's steroid-based hormones. Okay, so this layer secretes mineralocorticoids. Main one is a hormone called aldosterone. So this aldosterone, we can expect that it has something to do with the regulation of certain minerals and ions. Okay, the intermediate layer, which is the zona fasciculata. This zone is responsible for secreting glucocorticoids. Again, we can guess from the name that it has something to do with glucose levels. And the main hormone here is cortisol. Don't worry, the names may seem overwhelming. We're going to talk about in detail about each and every one of them. The innermost layer of the cortex is the zona reticularis. Reticularis means net-like arrangement, and as you can see, the cells are arranged in a net-like arrangement. And this layer is responsible for secreting gonadocorticoids, which are sex hormones, but from the adrenal cortex. Okay? Now you don't need to focus too much on the slides. It's mainly going to be the explanation. So mineralocorticoids, as we said, minerals. So the secretion of this layer, it's coming from which zone? The mineralocorticoids, the zona glomerulosa. Okay? When we say ions or salts, what are the two most famous ions that come into your mind?
Sodium, potassium.
Sodium, potassium, right? So their regulation is extremely important. And sodium is actually the most abundant extracellular cation in the extracellular fluid. Okay? Can anyone tell me why is sodium important? Like, what are some of the functions of sodium?
Maintaining the membrane potential.
Yes. And who sets the resting membrane potential?
Sodium and
Potassium, yeah. The resting membrane potential, potassium. And also we have a general rule. You have to keep this in mind. Where sodium goes, water follows. Okay? So for instance, if you have elevated levels of sodium, water is going to follow it. So elevated levels of sodium means elevated blood volume and elevated blood pressure. Okay? This is just giving you some important functions of sodium, because we need to know why are we studying these mineralocorticoids, specifically aldosterone. This is why, because it regulates the level of two things, sodium and potassium. Okay? We're going to get into details about what it does to each and every one of them. And then, as you mentioned, we have potassium. Potassium sets the resting membrane potential. So now we know we have the adrenal cortex. We have three layers. First one is glomerulosa, secretes mineralocorticoids, mainly aldosterone. Aldosterone responsible for the regulation of two things, sodium and potassium. Okay, so we want to know what exactly does it do, this aldosterone. Aldosterone, again, I'm going to give you small terms, keep it in mind, it will help you build the other ideas on it. Aldosterone loves sodium and hates potassium. Okay? So aldosterone is going to be secreted, or when it's secreted, it's going to elevate the levels of sodium and decrease the levels of potassium. Okay? So when do we need aldosterone? In a state of high or low sodium levels? Low sodium levels, or low blood pressure, or low blood volume. They're all correlated together. And do we need aldosterone when the amount of level of potassium is high or low? High, exactly, because aldosterone hates potassium. So whenever potassium is high, aldosterone is stimulated and it's going to do its job. Okay? Okay, so now we know what aldosterone does. We spoke about what its work. Now we want to know, again, aldosterone, just like we said before, is a hormone. And a hormone is a mechanical thing. So aldosterone is not going to do these jobs all by itself. It needs some organ to affect. And this, aldosterone is going to affect an organ. This organ is going to elicit these effects, which is raising the levels of sodium and lowering potassium. What is this organ? Or what is the target of aldosterone? It's the kidney tubules. Okay? The kidneys are constantly filtering our blood and our circulation. Okay? In the circulation, we have many ions, many salts, including which sodium and potassium. Just keep in mind, these are the kidney tubules. Whatever stays in the kidney tubules is going out of the body with the urine. Okay? So what aldosterone is going to do is going to reabsorb sodium, because why again? Aldosterone loves sodium. So it's going to reabsorb sodium from the kidney tubules so that it's not going out of the body because we need sodium. And it's going to excrete potassium into the kidney tubules so that it can go out of the body. Is this point clear?
Yes.
Aldosterone, it loves sodium, so it's going to reabsorb it, and it's going to excrete potassium out of the body. Okay? So we have a couple of points to mention. These regulatory effects of aldosterone are relatively brief, so they don't last for long times. So they are mainly for short time adjustments. It involves the synthesis and activation of protein pumps because it needs some way to regulate these, such as the sodium potassium ATPase, which is the pump that exchanges sodium for potassium. And again, if I ask you a question in general, what state stimulates aldosterone secretion? Is it high blood pressure or low blood pressure?
Low pressure.
Low blood. Is it high blood volume or low?
Low.
High sodium or low sodium?
Low.
And high potassium or low potassium?
High potassium.
Exactly. Okay? Okay. Again and again, aldosterone is a hormone. It cannot think by itself. You just bring aldosterone, tell it to do its job, and it does this job. So we need some higher system that has a brain, and it can control when do we secrete aldosterone. Okay? We need something to sense when there's high blood pressure or low blood pressure, so that we know, do we secrete insulin now or not, aldosterone now or not. Okay? So these are the mechanisms that regulate aldosterone secretions. This may seem overwhelming, but just understand what is this. Don't worry, it's going to be easy. This is the mechanism that regulates aldosterone secretion. Okay? We have primary regulators and secondary regulators. The primary, we have direct and indirect way. The direct way, we already spoke about it. When you have high potassium in the blood, is aldosterone going to be secreted or not? Exactly. So high levels of potassium are going to directly stimulate the adrenal cortex. Which layer of the cortex?
Granulosa.
Glomerulosa, yes. The zona glomerulosa is going to be stimulated, the zona glomerulosa, which is in the cortex, to release aldosterone. Aldosterone is going to bring down the potassium levels. Okay? Easy and simple. Now for the indirect way, and this is like the primary regulator. This mechanism controls mainly when is aldosterone secreted. Just sneak peek, keep in mind angiotensin 2. Okay, we need to get to angiotensin 2. Now, let's start from the beginning. First of all, as we said, it's released in a state of low blood volume and or low blood pressure. So first we need something to sense that we have low blood pressure or low blood volume, right? Makes sense because we have to know it first, then do something. So what senses this drop in blood pressure? A group of cells in the kidney, and they're called the juxtaglomerular complex. Okay? So the name is a bit complicated, but it's easy. Juxtaglomerular complex cells, they are a group of cells in the kidney and they sense the drop in blood pressure. What do? They secrete into the blood something called renin. Okay? Renin. Normal. And then in the plasma, you have a protein called angiotensinogen. Okay? So renin is going to go and find this angiotensinogen and it's going to split the angiotensinogen. It's going to give us angiotensin 2, which is the one that we mentioned in the beginning, which is the one that's going to go to the cortex, zona glomerulosa, and stimulate aldosterone secretion. Does this point make sense?
Yes.
Quickly again, we need something to sense the drop. So the juxtaglomerular complex and the group of cells in the kidneys are going to sense the drop. What are they going to do about it?
Renin release.
They're going to release renin. Renin is going to split
Angiotensin 1 to
angiotensinogen Okay? And the result is going to be angiotensin 2. And the final effector for this mechanism is the angiotensin 2, which is going to cortex, stimulating aldosterone secretion. Okay? Now for the other factors, they're not really a primary, they're secondary factors. Normal elevated ACTH levels, usually, as we said, we have cortex, we have 3 layers. The first layer, which is the zona glomerulosa, usually it's not affected by ACTH levels, okay? But during severe stress, or not severe stress, during very high amounts of ACTH, you need very, very high amounts of ACTH, it could have some effect on the zona glomerulosa of the cortex and cause it to directly stimulate aldosterone secretion. Okay? That's why it's not primary, because you need very high levels of ACTH in order for the zona glomerulosa to be a little stimulated and secrete aldosterone. Okay? So these 3 mechanisms are mechanisms that help secrete aldosterone. What if it's the other way around? What if our blood pressure is already high? What if our blood volume is already high? So we need something called an inhibitory effect, right? We need something to inhibit aldosterone. Because as you guys answered before, you said when there's high blood pressure, we don't need aldosterone. So there's something called ANP, or atrial natriuretic peptide. Basically, the heart secretes this peptide when it senses there's high blood pressure, because the heart is constantly pumping blood. So when there's high blood pressure, the heart is going to sense this and secrete this ANP, and atrial natriuretic peptide. This ANP is going to inhibit aldosterone secretion and mainly inhibit the primary regulatory effect that causes aldosterone secretion. Okay? Do you understand these 4 mechanisms? 3 of them are responsible for secreting aldosterone. The indirect way is the main one, and we have 1 inhibitory mechanism. And as we said, aldosterone, what's going to do? It's going to go to the kidney tubules, stimulate reabsorption of sodium, because it likes sodium, put the sodium back into the blood. Who's going to follow sodium? Water, bringing the blood pressure and blood volume back up again, and getting rid of potassium. So the blood volume will reach its normal homeostasis level. Okay, now this was the normal scenario that we spoke about. What if we have very high amounts of aldosterone? Something that's causing hyper secretion of aldosterone. And it's a condition called aldosteronism. First of all, what do you think is the cause? We have to speak about the cause. Usually the cause is tumors. So in the adrenal gland, back again, you have a tumor. This tumor is causing hyper secretion of aldosterone. Before you even read, aldosterone, we said, what does it do to sodium? Increase. And what does it do to potassium?
Increase.
Okay. So when we have extremely high levels of aldosterone, we can expect that we're going to have 2 sets of problems. One is related to the high levels, extremely abnormally high levels of sodium, and the other one is due to the extremely low levels of potassium. As we said, extremely high levels of sodium is going to drag water with it. It's gonna what is this going to do to the blood pressure? Increase, so it could cause hypertension, and when water follows in extremely high amount, it could cause edema. Okay, as you can see in the picture. Now this is the first set of problems. The other set of problems is related to the extremely low amounts of potassium. Okay, so the extremely low amounts of potassium could cause neurons to become unresponsive, muscle weakness, and eventually it could even cause paralysis. Does this make sense?
Yes.
This is the effect of aldosterone. Raises sodium, lowers potassium. These are the 2 major sets of problems related to the extreme or hyper secretion of aldosterone. It's called aldosteronism, and usually the cause is adrenal tumor. Okay, we have a question. I need someone just to read. You don't have to answer. Anyone? Okay.
Atrial natriuretic peptide is opposite of the action of which of the following hormones?
Okay. Just take some time to think. If you understood this, just take some time to think. The answer is going to be very easy. Yes? B, aldosterone, yes, exactly. Because we said the 4 mechanisms, 3 of which they increase aldosterone. One of them is inhibitory, which is the AMP, and it inhibits aldosterone secretion. Catch. Okay, we have another question. Okay, who wants to read? Just read, you don't have to answer.
Which of the following conditions would result from hyposecretion of aldosterone?
Again, these kind of questions you can never answer very quickly. You need to think. Just take some time. Anyone has the answer? Yes?
Oh, I was gonna say A.
A? Decreased heart rate? How?
Oh wait, isn't it stimulated by hypotension, aldosterone?
Stimulated by hypertension.
Oh, okay.
All the other 3 mechanisms are stimulated by hypotension to increase aldosterone, to increase every blood pressure, blood volume. No, this mechanism, the AMP is hypotension.
I say it's C.
C, dehydration. Why?
Because if we think sodium oxide, we don't think normally water or foam, so dehydration.
Exactly. So again, Mustafa. Okay. So again, when you see this kind of question, the first thing that should come to your mind is what is aldosterone's job? We said if you have high aldosterone, high sodium, low potassium. Here, they're saying we have low aldosterone. So it's going to be the opposite. Sodium levels are going to drop. So which means sodium is going to go outside the body. Who follows sodium? Water. So this is going to cause dehydration. Understood?
Yes.
Okay. Adrenal cortex, 3 layers, zona glomerulosa, mineralocorticoids, aldosterone, we're done with it. Now to the intermediate layer, which is the zona fasciculata. Secretes glucocorticoids. We can sense that it has something to do with glucose levels. We have many hormones secreted from this layer, okay? But the main one is cortisol with an L. Cortisol or hydrocortisone, only one secreted in high amounts. The other hormones include cortisone with an N and corticosteroid. We're mainly going to be focusing on cortisol. So this is regulated by the negative feedback inhibition. What does this mean? This layer is stimulated by ACTH. ACTH is coming from where? Adrenocorticotropic hormone. From the pituitary. Okay, and what stimulates this ACTH? From the hypothalamus. Releasing hormone, okay, which is CRH, corticotropin releasing hormone. So we have the hypothalamus. This axis is one of the main or the most important thing in the endocrine chapter. It's an axis. You have hypothalamus releasing, either releasing or inhibiting hormones. Going to the pituitary, if it's a releasing hormone reaching the pituitary, it's going to cause the pituitary to release hormones. If it's an inhibiting one, inhibition. So this axis stimulates this. How? From the hypothalamus we have CRH, corticotropin releasing hormone. Goes to the pituitary. Cause the pituitary to release ACTH or adrenocorticotropic hormone. Okay? This ACTH is going to go to the adrenal gland, to the adrenal cortex, and stimulate the secretion of the glucocorticoids. Okay? From which zone of the cortex? Zona fasciculata. Okay? And cortisol is going to be released. Do you understand this mechanism? And what do we mean by negative feedback inhibition?
As it increases, it stops itself.
Exactly. The product, which is cortisol or the glucocorticoids, if they are elevated, they're going to act back on the pituitary, cause it to stop releasing which hormone? ACTH. Okay? Pituitary stops releasing ACTH. this layer of the adrenal cortex, which is the zona fasciculata, is going to stop releasing glucocorticoids. Okay? Stressors, and what do we mean by stressors? Any stress to the body, such as hemorrhage, infection, trauma, it affects the normal cortisol levels. And I already spoke about this in the beginning. We said higher CNS centers, they override the inhibitory effects because during stress, during physical stress, when someone is injured, they need the higher glucose levels. So even if you have high glucose levels, we cannot have the high glucose levels or glucocorticoids inhibiting the CTH. We need more glucose. This is a special scenario. This is when your body is under stress. So the higher CNS centers are going to override this inhibitory effect and cause the pituitary to keep secreting ACTH to keep the glucocorticoids and glucose being secreted. Okay? Okay. The actions of this, as we said, mainly is elevating the glucose levels in the body, as well as fatty acids and amino acids. Primary effect, and I think you're all familiar with this term, gluconeogenesis. Gluconeogenesis, formation of glucose from non-sugar molecules. Okay? The second effect, it enhances the sympathetic nervous system's vasoconstrictive effects. Again, during stress, you want or you need the blood pressure to be high. One of the mechanisms is to constrict the blood vessels. But this is a secondary effect, okay? And enhances which division of the nervous system? Sympathetic, we have sympathetic and parasympathetic. The sympathetic one, think of it more of, it's like the branch of the nervous system that's activated during fight or flight situations, during stress. So you're nervous, you're sweating, your heart is beating. The parasympathetic is when you're resting. We call it rest and digest mode. Okay? Just keep it in mind. Now we spoke about all these good effects of glucocorticoids and I'm gonna say cortisol. What if we have too much or very high levels of cortisol? It's gonna cause two very dangerous things. It has an anti-inflammatory effect and an anti-immune effect. Now an anti-inflammatory and an anti-immune effect is not that big of a deal until something harmful tries to enter your body and your immune system is down and your inflammatory response is down, so your body won't be able to protect you. Okay? So this is very important and dangerous because patients who usually have chronic, which is long-term inflammatory disorders, the doctors prescribe glucocorticoids. Why? Because it has an anti-inflammatory effect. But this could backfire because excessive levels of glucocorticoids will cause anti-immune effects. It could depress bone formation, cartilage formation, inhibit inflammation, as we said, and the main one, it will depress your immune system. And this is extremely dangerous. Simple things that you don't even notice, you're protected from them by your immune system. When this immune system is down or is weakened due to excessive levels of cortisol, it's going to cause severe complications, or it could cause severe complications. For the homeostatic imbalance, I don't like to summarize it because each and every word is extremely important and you have to read it slowly and carefully. Now, just take some time to read the first paragraph, first 5 lines, and then I'm going to ask you a question, simple question. Just read the first 5 lines till here. Just the first 5 lines. Okay? Did you finish? What is the difference between Cushing's syndrome and Cushing's disease? Since you read the first 5 lines. Don't read again. You already read it once. Anyone notice the difference? Yes?
I think the Cushing's disease is caused by the tumor.
Exactly. And the Cushing syndrome?
Just like in the high persecution.
Exactly. Yes?
It's more likely medication, the Cushing's disease. The syndrome is, he said that it's pituitary tumor, but the disease, it's more for medication. It's by medications?
No. The disease, so in general, elevated levels of glucocorticoids is called Cushing's syndrome. Sorry, Cushing's syndrome. This is in general when you have elevated levels of glucocorticoids, regardless of the reason. If the cause of this elevated levels of glucocorticoids is a tumor, an ACTH releasing malignancy, this is called Cushing's disease. And we actually had a question about it in the previous year. It was a matching question, and I don't remember it mentioned just elevated glucose levels or just elevated glucocorticoids, or there was a tumor, and you should know which one was Cushing's syndrome and which one was Cushing's disease. So that's why I don't like to summarize these homeostatic imbalances, because I need you to read it carefully. Yes?
So the last part is like, however, it's most often result of the clinical administration
Yes.
of drugs, the glucocorticoid drugs, it's for both the syndrome and disease?
No, when you speak about the disease related to one thing, tumor. Okay? So if this elevated glucocorticoid levels is caused by a tumor, so you know, as we said, above the kidneys, adrenal glands, right? If you have a tumor in the adrenal gland, and this tumor is causing hypersecretion of glucocorticoids, we call this Cushing's disease. If for any other reason, we call this Cushing's syndrome. Okay? And we're going to look at what is the main reason that people suffer from this syndrome. Most often, as we said, the most often reason why people have glucocorticoids excess is actually because of the drugs. As we mentioned, many people they suffer from chronic inflammatory disorders, and so they're prescribed glucocorticoids. Because why? Because they have an anti-inflammatory effect. To suppress this inflammation, they take this and it relieves them from the disorder. But this could be one of the downsides of it. Okay? So this was the cause. What are the characteristics? Logically, we're going to expect high levels of persistent elevated glucose levels. We call this steroid diabetes, because diabetes that's caused by steroidal hormones, which are the glucocorticoids. I don't know if I mentioned this or not, but they're called mineralocorticoids, glucocorticoids, gonadocorticoids, because they are steroid hormones. Okay? Dramatic loss in muscle, bone protein, water, salt retention, hypertension, all of these things. Okay? And we have this is sort of like we call it differential diagnosis. If you see these signs, there's most probably you can point what this patient is suffering from, which are called the Cushingoid signs. Okay? So these signs are usually involved with patients who have this disease, which is Cushing syndrome or Cushing's disease. What do they involve? As you can see, we call it moon phase, redistribution of the fat into two areas, abdomen and posterior neck. It causes what we call a buffalo hump. As you can see in the picture on the right, fat distribution is different. It's centralizing in the area that is at the back of the neck. Okay? And we here also have poor wound healing. Why poor wound healing? Because excess glucocorticoids have anti-inflammatory and anti-immune effects, exactly. So you'll be more prone to infections, and infections could be severely dangerous before they produce symptoms. Okay, so it's sort of like almost very late for you. Okay, what is the treatment? If it's caused by a tumor, the only treatment is to surgically remove the tumor. If it's caused by the drugs, glucocorticoid drugs, then you should discontinue the drug. Okay? So this disease was related to excess glucocorticoid levels. What if it's the other way around? What if we have low levels of glucocorticoids? Addison's disease. And Addison's disease is actually more related to both layers of the cortex. The first one, which we spoke about, releases mineralocorticoids and aldosterone. The second one, which is glucocorticoids. Addison's disease usually involves hyposecretion of both of these layer secretions. So you have low aldosterone and low glucocorticoids. Okay? So as you can see here, again, I don't like to summarize these homeostatic imbalances. It's going to cause dehydration. Why? Because also we have low mineralocorticoids. Sodium levels are going to drop. Why? Because low aldosterone again. And what about the glucose levels? Also drop. Okay. So corticosteroid replacement therapy is the usual treatment for this case. we give the patient has hyposecretion, so we give him drugs, corticosteroid replacement therapy. We have an early sign. We just mentioned the negative feedback inhibition, right? We have elevated levels of cortisol, acts back on the pituitary to stop making ACTH and then stop releasing cortisol. In the absence of the cortisol, is the pituitary going to keep releasing ACTH or stop? Like the level of ACTH is going to increase or decrease in the absence of cortisol? Increase. Why? Because it's not going to stop until the cortisol is elevated, acts back on the pituitary to stop it from secreting ACTH. In case of low cortisol levels, ACTH is going to keep being secreted, right? So elevated levels of ACTH are actually going to stimulate the melanocytes, which are the pigment cells, trigger the melanocyte to melanin production, okay? So one of the characteristic signs of this Addison's disease is bronzing of the skin, okay? Do you understand why this bronzing of the skin happens? Because?
ACTH activates melanocytes.
Yes, and why do we have elevated ACTH levels? Because cortisol levels are low, they're not inhibiting the pituitary, and the pituitary keeps secreting ACTH more and more, which stimulates the melanocytes. Okay, so we have a question here. Who can read the question? Just read for you to answer.
A 46-year-old woman comes to the clinic and diagnosed with Cushing's disease. Which of the following hormones is the reason for this disease?
Anyone? Yes? Cortisol. Anyone doesn't know why? We said Cushing's disease is elevated levels of glucocorticoids, right? And glucocorticoids, when we speak about glucocorticoids, the main hormone is cortisol. So a patient suffering from Cushing's disease is going to have elevated levels of cortisol. This is one of the most simple questions that you can get in the exam. Okay, now we're done with the first two layers of the cortex. The outer one, which is zona glomerulosa, which secretes mineralocorticoids, aldosterone, we're done with that. The intermediate layer, zona fasciculata, glucocorticoids, we're done with this. Now we have the innermost deep layer of the cortex, which is the zona reticularis. Now the secretions of this layer are not significant. They mainly secrete gonadocorticoids or adrenal sex hormones. So usually or normally the sex hormones, the main source of sex hormones is from the reproductive organs. But in here we have this layer of the adrenal cortex, which is the zona reticularis, secretes sex hormones. They are weak androgens. Usually they are converted in the tissue cells to more potent male hormones. Okay? What are some examples of the most? Testosterone and sometimes to estrogen. Okay? So they're converted in the tissue cells. In adult women, it's found to have some effect, such as partially responsible for the sex drive and estrogens after menopause. Because after menopause, estrogen levels in females go down. One of the main sources for estrogen after menopause is the gonadocorticoids from the adrenal cortex. Okay, so as we said, it's mainly male hormones. So when it's in males, you don't usually expect that big of an effect. Why? Because males already have testosterone, testicular testosterone from their reproductive organs. So extra gonadocorticoids or hypersecretion of gonadocorticoids, which we call adrenogenital syndrome or masculinization, it's not going to have that big of an effect on males. It's mainly going to have an effect as early maturation of the reproductive organs, okay? And this is like the main effect, yeah, exactly. And sex drive emerges with vengeance. This is in males. What do you expect in females? Is this going to be more of a problem in females?
Yes.
Yes. Why? Because it's causing, keep this word in mind, masculinization. Okay. Why? Because it's going to cause the woman or the female to develop a beard and hair distribution in like a man-like hair distribution. Okay, so this has a much bigger effect on females than males. As you said, hypersecretion of gonadocorticoids, it's called adrenogenital syndrome or masculinization. In adult males, not noticeable, and the reproductive organs mature and the secondary sex characteristics appear a bit early. Okay? Do you have a question? Anyone read from that side? Okay.
A 19-year-old girl presents to your clinic with a masculine pattern of hair development, which is a phenomenon organs/cells secrete the hormone responsible for these characteristics.
Simple one. Okay. D, which is the inner layer of the adrenal cortex. Exactly. Anyone need further explanation? Masculinization caused by excess gonadocorticoids. Gonadocorticoids, where is the source? The adrenal cortex, the deep layer, which is zona reticularis, or sometimes they mention inner layer of the cortex. Okay? Now we're done with the cortex. What do we have left? The inner medulla. The inner medulla is more of like a knot of nervous tissue. And this is one of the few examples that you have neural stimulation. Okay? What do we mean by neural stimulation? That this group of cells are stimulated to secrete their hormones neurally. So as we said, mainly medullary chromaffin cells, they are actually modified post-ganglionic sympathetic neurons, so they are modified neurons. So they're a group of cells. Okay, we need to know, what do they synthesize? Epinephrine and norepinephrine. We call them catecholamines. These secretions of the medulla especially help us cope with short-term stress. Okay? They secrete epinephrine and norepinephrine. When do they secrete the catecholamines?
In stressful situations.
Stressful situations, exactly. As you can see, when the sympathetic nervous system activation and when you're in a fight or flight status. Okay? You need these hormones. Why? We're going to see the effects of these hormones. So what do they do? Why are they secreted during stressors and during fight or flight situations? They basically prolong or reinforce the fight or flight status or the fight or flight response. Okay? So they are actually not essential for life, but they have a role in the fight or flight response mainly. And are they catecholamines secreted in equal amounts?
No.
No. You have 80% epinephrine and 20% norepinephrine. Okay? They're usually or mostly the same, but we have similar few differences. The epinephrine is actually a dilator of the small airways, which are called bronchioles. Okay? So imagine you're in a fight or flight situation, you see like a big fire and you're trying to run. Would you breathe slowly or fast?
Fast.
Fast, and you're going to need as much air as possible to go in and out, and you're going to be breathing fast. So you expect the airways to be dilated or constricted? Dilated, to allow as much air as you can, right? So epinephrine is a dilator of small airways or the bronchioles. Some of the clinical use of epinephrine, clinical use means some patient came to you, to the clinic, suffering, for instance, from asthma attack. Asthma attack is basically constriction of these small airways. So what do you give them?
EpiPen.
EpiPen, which is epinephrine. The content of the EpiPen is mainly the epinephrine. Why? Because it dilates the small airways. Okay? What about norepinephrine? Norepinephrine has more actions on increasing or peripheral vasoconstriction. Peripheral means the periphery, and vasoconstriction because you need your blood pressure to go up. Okay? So it will increase the blood pressure. Again, very important, the homeostatic imbalances. I'm going to read it word by word. The deficiency in adrenal medulla hormones is not a problem. Why? Because as we mentioned, they're not essential for life. Okay? They just prolong and reinforce the fight or flight response. they intensify the activities, okay, set into motion by which branch of the nervous system? Sympathetic or parasympathetic? Sympathetic. Okay, unlike glucocorticoids. On the other hand, what do you expect if you have extremely high levels of catecholamines, hypersecretion of catecholamines,
High blood pressure.
high blood pressure, high metabolic rate? Basically, you're going to be constantly feeling as if you were, or your body is going to be constantly be as if it was in a fight or flight situation. Okay? So increased heart rate, increased metabolic rate, increased, you're going to be sweating, palpitation. Usually it's caused by a
Fight or flight situation.
tumor. Yeah, the hypersecretion of the gonadocorticoids usually caused by a tumor. And we call this pheochromocytoma. Pheochromocytoma. This tumor is in the medulla, causing hypersecretion of, sorry, I said gonadocorticoids. It's not gonadocorticoids. It's catecholamines. Okay? Increasing catecholamines, hypersecretion of catecholamines. We call the tumor pheochromocytoma, and these are some of the symptoms. High metabolic rate, as you said, high blood pressure, high everything. Okay, we said it's neurally stimulated. How? So the hypothalamus, it doesn't follow the normal axis of the endocrine, where you have hormones from hypothalamus, pituitary, etc. As we said, one very important thing here, it's during short-term stress. Okay? Fight or flight, so short-term stress. What happens? Action potentials, they travel from the hypothalamus, going all the way to the medulla. They cause the medulla to secrete catecholamines, which are epinephrine and norepinephrine. So this is basically how it's stimulated, okay, neurally. And as we said, one of the few examples of neural stimulation. What do those epinephrine and norepinephrine do, or the catecholamines? As we already mentioned, elevates the heart rate, elevates blood pressure, dilates the bronchioles, and increases the metabolic rate. Okay, we have a question here. Who wants to read? Okay.
A 28-year-old female suffering from a tumor of the adrenal medulla. Which of the following best describes the condition of this patient?
You can go by one. Increased body hair growth like a male.
Should I read them?
No, like, do you think it's right or wrong?
Let me just read.
Okay.
I think it's B.
B, severe depression of the immune system. What do you guys think? Anyone has another answer?
C.
C. Why?
Because the epinephrine.
Increased catecholamines. So we have to just know what is the, first of all, we have to know tumor in the adrenal medulla causes hypersecretion of what? Epinephrine, norepinephrine, which are the catecholamines. Second thing we need to know is what is the function of these catecholamines? As you said, fight or flight response, so they increase heart rate, increase blood pressure. Okay? Increased body hair growth like a male. This is caused by excessive levels of which hormone?
Androgen.
The gonadocorticoids, yes. Okay? From which layer? Zona reticularis. Just keep the zone names in mind, because sometimes they don't just say gonadocorticoids, they say the hormones that are secreted from this layer. Okay? Now we're done with the adrenal gland. We have another small gland, which is pineal gland. Don't worry, this is short. We have to know a couple of things about this gland. First of all, the location. It's pinnacle shaped, and it is in the diencephalon. It hangs from the third ventricle of the. It hangs from the roof of the third ventricle. Okay. What is the structure? It contains mainly pinealocytes, which are the secretory cells, and they are arranged in clusters. Dense calcium salt deposits make it visible in X-rays. This piece of information is also important. This gland has dense deposition of calcium. In X-rays, it makes it visible. Okay? So if I give you a question, which of the following is the location of the gland that appears in brain X-ray? Again, which of the following is the location of the gland that appears in the X-ray, in brain X-ray? So the answer would be the gland that hangs from the roof of the third ventricle. Okay, so don't expect the questions to be very direct, just pineal gland. Okay, have an idea about the location and the structure. So it would be, the questions might come in this way. Okay, the main hormone, melatonin. Melatonin, which is the hormone that makes us feel drowsy, makes us feel we want to go to sleep. Okay, it follows a diurnal cycle, of course. So melatonin helps us sleep. Levels of melatonin will be high or low in the morning. What do you think? Low. And at night it's going to high. Okay, and also plays a role in antioxidant production and detoxification. Okay, as we said, mainly responsible for regulating the circadian rhythm, or the biological clock, or the sleep cycle. The mechanism in which it receives the stimulus is not direct, so the retina receives the signal lights, then it goes to the hypothalamus, and then to the pineal gland. Exposure to bright light is going to elevate melatonin or decrease melatonin. That's why even in social media you see these health people, they tell you when you wake up, try to get exposed to sunlight. Why? When you're exposed, you're suppressing melatonin, basically telling your body that I woke up. Okay? And at night, they also tell you, try to reduce your screen time so that you have less light coming and you have more melatonin production to make you feel more drowsy and like you want to go to sleep. Okay? Sleep regulation, body temperature and appetite. And it has been found that in children, it actually delays puberty by inhibiting the sexual maturation. This is called anti-gonadotropic effect. Okay? The gonadocorticoids from the cortex, this has an anti-gonadotropic effect. Okay, so it delays puberty. So if you see a question with a patient with elevated levels of melatonin, would you expect him to have early or late maturation? Late maturation, okay? And it has some role in animals, mating behavior, and another size. We have a question here. Who wants to read?
32-year-old man traveled from Japan to the United States by Emirates Airlines. After reaching the destination, he feels drowsy during the daytime but stays up at night. Which of the following hormone secretion is disturbed in this person? C.
Okay. Melatonin, which is responsible for setting the biological clock and the sleep cycle. Okay, we're done with the pineal gland. Okay, now we come to the pancreas. This is the last thing. So the pancreas is what we call a mixed gland. Why mixed? Because it has both endocrine functions and exocrine functions. The endocrine, secretion of hormones. We're going to see which hormones. And the exocrine functions is that it secretes an enzyme-rich juice that aids in digestion. Okay? The location of the pancreas, it's in the abdomen, behind the stomach. The structure, as we said, it's a mixed gland. The majority of the pancreas is made of what we call acinar cells. Okay? These acinar cells, they have this job of secreting this enzyme-rich juice that aids in digestion. Okay? So the majority of the pancreas is made by these cells, the acinar cells. What about the hormone secretory activity? Well, scattered among the acinar cells, we have what we call islets of Langerhans, or pancreatic islets, basically groups of cells. These groups of cells, we have two main types. We have alpha cells and beta cells. Okay? Quick recap, we have pancreas, which is a mixed gland. Most of it is made by acinar cells. which secrete an enzyme reduced that aids in digestion. Scattered among these acinar cells, what do we have? Pancreatic islets, or we call them islets of Langerhans. They are the ones responsible for the hormone secretion. What type of cells can we find in these islets? Alpha cells and beta cells. Okay? Alpha cells secrete glucagon, and beta cells secrete insulin. Glucagon, from its name, we expect it to, what does it do to the glucose levels? Increase. We call it hyperglycemic, okay, because it increases the level of glucose in the blood. Insulin, which is secreted by the beta cells, we call it hypoglycemic, because insulin's main job is to lower the glucose levels in the blood, okay? And we have some additional hormones, somatostatin and pancreatic polypeptide. The somatostatin regulates insulin and glucagon release, and the pancreatic polypeptide influences digestion and appetite. Okay. Again, so we said glucagon increases glucose levels, insulin decreases glucose levels. So glucagon secreted in high or low levels of glucose. High or low levels. Glucagon. When is glucagon secreted? Low level. Hypoglycemia. Why? Because we needed to elevate levels of glucose. Insulin, on the other hand, is secreted in a state of hyperglycemia, especially after a meal. You have high glucose levels. Insulin is released to bring the glucose levels in the blood down. Okay? As you said, hypoglycemic hormone released when glucose is high. And what does insulin do? The key thing here, you have to know, insulin, first of all, most, not all, most our body cells, they need glucose. Glucose is their currency of energy. All the cells need energy, they need glucose. Okay? Insulin is like the key. No matter how much glucose you have in your blood, if you don't have insulin, which is going to allow glucose entry into the body cells, your cells are going to starve. Most of our body cells need insulin to allow glucose entry. Most, okay, not all. We're gonna see why. And so yes, this is how glucagon and insulin, they work together and they are antagonistic to each other, okay? So they have opposing function. One brings glucose levels up, which is hyperglycemic, and released when the body is glucagon, when the body has hypoglycemia, exactly, okay? And insulin, vice versa. So let's talk more about glucagon. It's a 29 amino acid polypeptide, so it's a polypeptide secreted by, as we said, alpha or beta cells, alpha cells of the pancreatic islets. And it's very potent. What do we mean by potent? Potent means very small amounts cause huge effects. Okay? So the effects of glucagon, as you can see, one molecule of glucagon can trigger the release of 100 million glucose molecules into the blood. This is what we mean by potent. Only one molecule can cause 100 million molecules of glucose in the blood. And again, glucagon is a hormone. Okay? So it cannot elicit these effects by itself. So it needs something or some organ to act on which can elicit these effects. So who is the primary target for glucagon? The liver. Okay, so this is the liver, this is glucagon. We have low or high blood levels of glucose? Low. Glucagon is going to go to the liver, which is its primary target. What is it going to do? It's going to three main processes, yes, which I think all of you are familiar with. Glycogenolysis, which is the breakdown of glycogen to release glucose. Easy and simple. The second thing is gluconeogenesis, which is the formation of glucose from other sources, fatty acids, amino acids, etc. Formation of glucose. And the third thing is direct glucose release from the liver. Okay? So glucagon causes these three things to happen in the liver when you are in a state of low glucose. You have low glucose levels in the blood. This is what glucagon does. Okay? Again, stimulated by low blood levels of glucose or hypoglycemia. Sympathetic nervous system activation it's activated sometimes by the sympathetic nervous system. As we said, sympathetic, fight or flight, during stress, you need elevated levels of glucose, so it's sometimes activated by this branch of the nervous system. And also, high levels of amino acids. So basically, amino acids and fatty acids, they're like sources that we can form glucose from, okay? So glucagon forms glucose. So whenever you have high amounts of these sources, which are fatty acids and amino acids, glucagon is going to be stimulated to make glucose out of them, okay? On the other hand, we're going to see how insulin tries to hide these sources away from making glucose, okay? So high amino acid levels, especially like after a protein-rich meal, is going to stimulate glucagon, okay? What is it inhibited by? The opposite. High blood glucose levels. Okay. Should I continue? I think I'll continue. You don't really need the slides. I'm just going to be taking a sneak peek at the slides. Inhibited by, again, as we said, high blood glucose levels, and it's also inhibited by which hormone? Insulin, exactly. Why? Because insulin is already released when you have high glucose levels. So glucagon is inhibited when it sees insulin. Okay, glucagon is like, it's afraid of insulin. And keep this in mind because we're going to see insulin is actually stimulated by glucagon. But glucagon is inhibited by insulin. Okay? Speaking more about insulin, it's a 51 amino acid peptide secreted by which type of cells of the islets of Langerhans? Alpha or beta? Beta cells. And it's actually, in the first, it's produced as proinsulin, and then just before secretion, it's enzymatically cleaved to release insulin. Main function, lower blood glucose levels. Okay, how does it do this? How does it lower blood glucose levels? Again, as we said, the main thing is it's like a key. So it increases the uptake of glucose by our cells. So it basically opens the doors for most of our body cells and allow glucose entry. Glucose levels in the blood are going to go down. What if we still have excess? Okay, so we already have cells. This cell needs energy, needs glucose. You have a big amount of glucose, you gave the cell, so the energy needs of the cell have been met. What if you still have excess glucose? Glycogen, okay? So these are activities. Now this is very important. We said insulin, what does it do to glycogenolysis? Does it promote or inhibit? Inhibit. But inside the cell, when insulin binds to the target cell, allows glucose entry. Okay, we have three things. First, we have three priorities. The first priority is the energy need of the cell. Okay, so glucose is going to go, the energy needs have been met. You have excess glucose. What does insulin promote when you have excess glucose inside the cell? Glycogen formation. Okay, so it forms glycogen, not glycogenolysis. Glycogenolysis means breaking down glycogen. Inside the target cell, because the needs of the cell have been met, it forms glycogen formation. And if we still have excess, then it's going to be converted into fat, especially where in adipose tissue. Okay? And as we said, the primary target of glucagon is the liver, where it does these three processes, the gluconeogenesis and glycogenolysis. Insulin also acts on the liver. What does it do to glycogenolysis in general? Inhibits glycogenolysis. Okay? But inside the target cell, it promotes the formation of glycogen if there is excess glucose. Okay? Now I mentioned that most of our body cells need insulin to allow glucose entry into their cells, right? Why most? Because we have liver, kidney, and brain. Liver, kidney, and brain cells do not need insulin to allow glucose entry into their cells. Okay? And it makes sense because when you have high levels of glucose, and even for the brain cells, which are the most important, some of the most important cells in the body, If there's no insulin, then it's not allowed. It doesn't make sense. So you need this immediate. You need the brain cells to receive glucose as immediately, as fast, and as soon as possible. Okay, so it removes a restriction from this whole process. Okay, liver, brain, and kidney cells, they take up glucose without insulin. And insulin also has some brain functions, neuronal development, feeding behavior, learning, and memory. These are some other functions of insulin. The mechanism of action, again, as we said, insulin binds to the target cell, okay, binds to its receptor, which is a tyrosine kinase receptor, and promote glucose entry inside the cell. And what does it do? What effects does insulin have inside the target cell? The three things that we mentioned. First, energy needs of the cell, then formation of glycogen, then fat if there's still excess glucose. Okay? Factors that stimulate insulin release. Stimuli, elevated blood levels of glucose, okay? Increased blood levels of amino acids and fatty acids. Okay? When you have high levels of amino acids and fatty acids, these are factors that stimulate insulin secretion. Okay? And any hyperglycemic hormone. Hyperglycemic hormone. So any hormone that brings glucose up, insulin is stimulated to bring the glucose levels back down again. Inhibition of insulin release, again, we already spoke about this. And then lastly, we have the homeostatic imbalances. This is the final 5 minutes of this chapter. So, diabetes. What is diabetes? We have two types of diabetes, which are type 1 and type 2. What is the difference? Anyone knows what is the difference between the two? Yes?
Type 1, actually the insulin isn't working properly, but type 2, no. The type 2 doesn't have working in a proper insulin.
Yes.
And type 1, I don't remember.
Type 1, yes.
Type 1, لما الانسولين
Exactly, so hyposecretion of insulin. You have low levels of insulin. This is type 1. Type 2?
receptors are destroyed on the cells.
Exactly, so the effect, so insulin is there, but its effect is reduced. This causes type 2 diabetes. Okay, medication inducing type 2 diabetes, you have some examples, you should read the homeostatic imbalance. Okay, just know the names of these medications. We have thiazide, diuretics, stains. Okay, that's why I said just read them. Okay, symptoms. So what do you expect when you have high levels of glucose? We said the kidneys are constantly filtering our blood, right? When you have excess glucose in the blood, this glucose is going to precipitate in the kidneys. This glucose, in the kidney tubules especially, this glucose will act as what we call osmotic, what do we call it?
Diuretic.
Osmotic diuretics, which means it's going to pull water towards it, okay? When it pulls water, glucose and extremely large amounts of water are going to go out with urination. We call this polyuria, which is frequent urination, okay? So it causes dehydration. This is one of the first symptoms, polyuria. The other thing is polydipsia. You're losing too much water, you're going to feel thirsty. So this dehydration is going to activate thirst centers in the brain, which causes polydipsia. Polydipsia means thirst, okay? Then we have polyphagia. We already spoke about this. When you don't have insulin, no matter how much glucose you have in the blood, the cells are still starving because you don't have the key that lets glucose inside the cells. So it's going to cause polyphagia, which is hunger, extreme hunger, and appetite. You understand why? Because there's no insulin, although you have elevated or high or normal, you have glucose, but you cannot use it. The cells are starving and they cannot use this glucose because the key is missing. Insulin is missing. Okay? So in this case, as a complication, what do you expect? So the body, although it has glucose, is going to think that there's no glucose. So it's going to start gluconeogenesis, or formation of glucose from non-carbohydrate molecules. One of the main sources is fatty acid. Okay? So the body is going to start mobilizing the fatty acids to try and make glucose. This will cause a condition called lipidemia, which is literally lipid in the blood. Okay? And fatty acids, they're acids, accumulation of acids. What will it do to the blood pH? Decrease the blood pH. So you're gonna have the patient is going to suffer from a condition called ketoacidosis. This fatty acid, the metabolites of the fatty acids are, we call them ketone bodies or ketones. Accumulation of these fat metabolites in the blood are going to cause a condition called ketoacidosis. Further complication is that these ketone bodies are actually negatively charged. Okay? So when they're going out with the urine, they are pulling positively charged ions with them, some of which are sodium and potassium, which are extremely important. Okay? In severe cases, disruption of heart activity, impaired oxygen transport, coma, or even sometimes death. Okay? Last thing, it's the other way around. We have hyperinsulinism. Okay? So we have excess levels of insulin. This causes hyper or hypoglycemia?
Hypoglycemia.
Hypoglycemia, exactly, because insulin is going to lower the glucose levels. Symptoms, we have anxiety, tremors, weakness, disorientation. Why? Because brain cells are not getting enough glucose. Insulin is getting the glucose levels down. Okay? Eventually, if it persists, it could cause even death. What could be the causes of this? Could be caused by many things, the most famous of which is actually overdose of insulin. As you know, diabetic patients, they have to take insulin, needles or I don't know in which form, they have to take insulin. So overdose of insulin could cause this. What do you think is a quick treatment?
Sugar.
Sugar, okay? Drink any sugar, eat any sugar. So quickly treated by ingesting sugar. And that's it. Thank you all for attending. I hope you got the most out of this session. And thank you to my colleagues, Hosna and Naya. And I hope you got something of this chapter. When you go home to read it, at least it'll be easier, and expose yourself to this chapter, any chapter, as many times as possible. Repetition will make everything easier for you. And good luck to all.
Thank you.